Thank you, Philippe, for the nice introduction. Thank you for the invitation. Thank you, Simon, which I met in Nesmo, and this was the beginning of me coming here. It's a real honor to be here in IQWiG. I'm following a lot the work you are doing, and to see such an audience here is really my pleasure. So today I will focus. The title is a bit changed in comparison to the original title. Today we will be talking about randomized trials only. Randomized trials is a big part of your activities, and there are many things to look in randomized clinical trial. I will be talking during 45 minutes, and there will be time for questions. I have no conflict of interest, and what we'll be covering first, the control arm. As you know, the control arm is not always so straightforwardly good, and we have many looks to look at in the control arm. Post-protocol care and subsequent therapy is a key aspect, and in a sense it's kind of affecting the control arm down the road after the first therapy. Trial design, we will cover this pretty fast because I really want to focus on endpoints and informative censoring and conclusion. So what should be the control arm? And first I want to give an example of a straightforward suboptimal control arm. The control arm ideally should be the best standard of care for patients that you are enrolling in your clinical trial. Here, it's a study, patient with pancreatic cancer, metastatic pancreatic cancer, first-line therapy, FOLFIRINOX against gemcitabine. This trial was very well known, an overall survival benefit, and led to the adoption in the community. I don't know if anybody here is treating patients with pancreatic cancer. Can you raise your hands? Yeah, I see some hands. This really became the standard of care with no doubt after this, and it was integrated in NCCN guidelines. Then come the Napoli 3 trial. Napoli 3, as you can see, it's also patient without previous treatment in the metastatic setting. Basically, it's again a first-line trial in metastatic pancreatic cancer, and it's comparing NALIRIFOX to gemcitabine nab-paclitaxel. Does anyone here know one big difference between NALIRIFOX and FOLFIRINOX? A big difference? Maybe you have it. It's not the compound exactly. The price. Yeah, the price. So here again, it's a triplet. It's a triplet, 5-FU, oxaliplatin, and this liposomal irinotecan. It's not irinotecan. But the comparator here, the main point I want to make, the comparator should not have been gemcitabine nab-paclitaxel. It should have been FOLFIRINOX. It should have been a triplet. It should have been the standard of care which we are giving to our patient. So FOLFIRINOX was published in 2011, and Napoli 3 started accrued in 2020. So to me, this is really a straightforward example of a suboptimal control arm. It got an overall survival benefit. It was approved. Okay. Now, let's go to some more tricky examples. Physician choice. This is one of my favorite examples, the ASCEND trial. Here, you have patients with triple-negative breast cancer, metastatic triple-negative breast cancer. And as you can see, the patient have received at least 2 lines of chemotherapy for advanced disease. So this is really heavily treated patients. And they were randomized between cetuximab povetacicept or treatment of physician choice. But what is this treatment of physician choice? It looks good, you know. I have a choice, I have a full choice, I'm very happy, you know. Is it a free choice or is it a restricted choice? And we looked at this with Vinay Prasad and Alison Aslam. We looked at all trials in oncology with control arm referred to as investigator or physician choice. And what we found, it was a pretty recent trend, starting in 2007. And as you can see, it's increasing very often in the New England Journal reports. You can see, again, physician choice therapy. In most cases, these are industry-sponsored trials. And in most cases, 85%, these are restricted choice. Okay, but now you can say, okay, Timothée, but these are restricted choice, but if they are mirroring the standard of care, what is your problem? I mean, you are, you know, annoying in some details, but if it's really the standard of care, what is your problem? Okay, I get your point, you know. Here, patients were heavily pretreated. At least 2 lines of therapy in the metastatic setting. And we have 4 choices: eribulin, vinorelbine, capecitabine, gemcitabine. So why I'm complaining? if you look very carefully, you will see that sometimes very important choices are missing. Platinum-based chemotherapy, we all know that it's very important in triple-negative breast cancer. 31% of patients were not pretreated with that, and it was not an option. Anthracycline, it was 17%. Maybe some of these patients could not receive anthracycline, but maybe it was also because of the availability or because of the trial design. Now let's look even further in detail. So now you will have to look into the supplementary appendix and into the protocol. Dose reduction and supportive care recommendation. As you know, when a patient will have toxicity, you will consider reduction of dose for the next cycle or sometimes supportive care recommendation. Here we take the example, of first occurrence of grade 4 neutropenia lasting for at least 7 days or grade 3 febrile neutropenia. If you were in the new therapy, statistical govitecan, and you had this toxicity for the next cycle, no dose reduction and mandatory GCSF. So the patient should receive GCSF. This can lead to higher dose, what we call dose intensity. If, on the contrary, you were on the physician choice chemotherapy group, then you would have a dose reduction for the next cycle, and GCSF were per physician discretion. Here, I just want to make a pause. This per physician discretion. We know these trials, many of them are conducted globally, including in countries where GCSF are maybe less available, So this kind of per physician discretion, you should always think about that. And of course, this can lead to a lower dose intensity. So in a sense, these rules is leading to higher dose intensity in the new treatment. Okay, now, I hear you again, you say, okay, Timothée, you are showing us this example of ascent, but okay, maybe it's very isolated, it seems to be, maybe you are cherry picking one trial like that. So we looked at all approvals over a 13 years period of time, again with Alison Aslam and Vinay Prasad, and basically we selected all trials where we could compare these dose reduction rules and GCSF rules. And our finding, we knew there were something, I didn't present all the other trials where we identified that. But our findings is in 10% of them, the rules were favoring the control arm, okay? But in 55% of them, it was favoring the experimental arm. So in this case, is the new drug truly better than the old one? Or outcomes driven by higher dose intensity? And we don't know. We don't know. Maybe it's just something that is, increasing the magnitude of efficacy. But I think it's something really to check. Now I want to talk about what I call misguided use of placebo only. Placebo only, you see some of these trials recently. I will talk about the FRESCO-2 trial. Patient with metastatic colorectal cancer, heavily pretreated, and they are progressed or be intolerant to TAS-102 and or regorafenib. As you can see, there is a lot of and or. You will see why it matters after. They were randomized between fruquintinib, which is a new TKI, or placebo only plus placebo plus best supportive care. So now again, some background, like the Napoli trial with the background of FOLFIRINOX. Here, the background we have is the CORRECT trial. The CORRECT trial was a trial published in 2013, and it showed that regorafenib was improving survival in those patients with already treated metastatic colorectal cancer. So it was approved in 2012, and FRESCO-2 accrued between 2020 and 2021. You have a PFS benefit, you have an overall survival benefit, you have an approval, but now I want to highlight something which is a bit surprising, In the protocol, you see that to prevent unintentional enrichment, the number of patients treated with previous regorafenib was limited to 50% of the total randomly assigned patients. What was the reason of that? Maybe you think that patients, if they have received and progressed after regorafenib, maybe another TKI won't be so effective. I don't know. I don't know what was really the reason. But actually, that happened. It was per protocol, so it was really followed. And 52% of patients did not previously receive regorafenib. And as we have seen in the correct trial, years before, we have seen that regorafenib is a life-prolonging therapy. So do you think it's ethical, appropriate to randomize this patient to placebo in the control group? And I think everybody has the answer, but there is another way to look at this is to see subsequent therapy. And when you see subsequent therapy, you see that in the placebo group, patient receiving placebo only, after the trial, 34% received an active anti-cancer therapy. So imagine that you have a patient suffering from a disease and you are randomizing this patient to placebo only, and after he's receiving 34 of them are receiving subsequent therapy, and as you can see, 8% of them receive regorafenib. So to me, this is really questioning the choice of placebo in the first place. We have published on this, you can check our paper, and I want to remind this in the Helsinki Declaration, in the paragraph about placebo utilization. They say that extreme care must be taken to avoid abuse of this option. And when you have significant rate of subsequent therapy, I think it's really a red flag. Now we wanted to look again, have a more broader picture, is it often or is it rare, and what is going on there? We did a cross-sectional analysis of FDA registration trial over many years, and pretty reassuringly, only 18 trials met our inclusion criteria. So you don't have a lot of these trials with placebo only or best supportive care only as a control arm. But what was very interesting, in blue, this is the rate of subsequent therapy in those trials. So you have the name of the trials, and in blue, and as you can see, the median is pretty high, is almost 50%. In orange is the rate of subsequent therapy in the experimental therapy, and of course, it's lower because the patient have received one more line when in the treatment, and the blue line is the difference, and it's again logical that you have more therapy in the control arm. Now, interestingly, we tried to see if the more the patient were deprived of an active therapy, the more an effect could be seen, in a sense. I don't know if you follow me. Are you following me? And we looked if there were any relation between rate of subsequent systemic therapy use and the hazard ratio. And what we found was there were an inverse association. With every 10% increase in control patients receiving subsequent therapy, there were 0.07 decrease in hazard ratio, which is pretty logical if you think about it. To conclude about control arm, I think this is really this image. You have a race, you have a winner, but there were rules favoring the winner, so you don't know if the run would have been win without those rules. So it's not so rare. In this work by Talalila and colleagues, they found that almost 17% of trials used for approvals were using suboptimal control arm. And these are my key points. I won't get into that, but these are really the point to check when you assess for a control arm. You're with me? Okay. Post-protocol. I know you are very interested by post-protocol, and I know you know I'm very interested by post-protocol, including crossover. So there are many terms, and sometimes it's a bit confusing. Post-protocol, crossover, post-progression. Post-progression is really in the advanced setting. You have a disease to have a progression, and when you talk about adjuvant, it should be post-recurrent. Sometimes there is some confusion. It's not a big deal, but we should be precise. Post-trial. I think subsequent therapy is probably the most accurate term, but very often we say post-protocol. I will very briefly talk about crossover. Usually in oncology, crossover is when control group patient, after recurrence or after progression, will receive the experimental therapy. And if you want to dive into this topic, I really recommend you to read this article. It's still totally up to date. Vinay Prasad, Alison Aslam, when crossover is good, when crossover is not good, and I think it's really a fascinating framework. I'm sure you are already familiar with this. Today I want to focus on one aspect of post-protocol care, is the lack of access to best care post-surveillance for control arm patient. And as you can see, it's really penalizing patient down the road. It's penalizing control patient down the road. So again, it's affecting the control arm, but after the first therapy. So it will not affect your PFS, it will not affect your DFS, it will affect potentially overall survival, which is still considered one of the most relevant endpoints in oncology. I will be talking about adjuvant CDK4/6 inhibitors. Is it a hot topic? What do you think? Raise your hand if you think it's a hot topic. Yeah, a lot of hands raised. Why it's a hot topic? Simply because it's potentially affecting a lot of women. These are data from Sweden. And as you can see, monarchy, we will be talking about monarchy and Natalie in detail. Monarchy or Natalie could affect up to 38, almost 40% of patients with newly diagnosed breast cancer, which is massive. Breast cancer is one of the most frequent centers of incidence. So it's really a hot topic. Now monarchy. What was monarchy? Monarchy was a trial with patients with hormone receptor positive, HER2 negative, high risk early breast cancer. The high risk is defined according to some very precise criteria. And they randomized in an open label fashion. It's important open label because I think it's potentially increasing the risk of some bias like informative censoring. And they received 2 years of adjuvant treatment. Abemaciclib, 2 years of abemaciclib, standard of care endocrine therapy, or standard of care therapy. And the question here I want to ask is really about post-protocol care in the control arm patient. Here, the question is adjuvant abema, and in control group patient that will have a recurrence, they should have access to CDK4/6 inhibitors. Why? Because we know in the metastatic setting that CDK4/6 inhibitors are standard of care. We could talk about the SONIA trial to say, is it first line, second line? I mean, we know it's part of the standard of care. And when you have that, this could be the situation, no overall survival benefit because of the dilution of effect. And this is okay, this is answering a question, earlier is not better than after, but you could also have a real overall survival benefit if patients in the control arm have proper access to CDK4/6 inhibitors. This would be totally okay. What you would not like is to have an overall survival benefit like here with a limited access to CDK4/6 inhibitors in patients in the control group after recurrence. This substandard access would bias towards an overall survival benefit. Is it logical for you? Any question? So, and why you have this limited access, I will explain after. I know you have already a clue. So these were the overall survival results of abemaciclib, the monarchy trial. It was presented during ESMO, and this was a highlight because the overall survival benefit is now positive. As you can see, a 1.8 absolute difference after 7 years, so it's a 1.8 absolute benefit. And here I really want to highlight what it means in terms of number need to treat. I think these kind of metrics, number need to treat, are very important to contextualize data, and even with patients. I mean, I think these are really important data. So here, 55 means that 55 patients need to be prescribed. I say prescribed because not all patients will really receive the 2 years of treatment, but prescribe 2 years of abemaciclib to save 1 life after 7 years. Now let's see, what I want to see, are these results really valid? Are these results partly driven by suboptimal access to post-protocol care? That's really the question I want to ask. So here you can see that this number of patients received any first systemic therapy upon recurrence. This number of patients received CDK4/6 inhibitors upon recurrence in the control arm, means that 204 patients, control patients, received a subsequent therapy that was not CDK4/6 inhibitors. And it's 7.2% of control arm patients. Okay, I see you're a bit puzzled by all these numbers. We have to put that on a figure. you have your 1.8% absolute benefit, and now you have this number of patients. You can't see well, I think. Maybe better, even better. Okay, so now you can see the difference. So you have this number of patients that did have a recurrence and a systemic therapy that was not containing CDK4/6 inhibitors. And my question is, would an overall survival benefit have been observed if at least a fraction of those 7.2 had access to CDK4/6 inhibitors upon recurrence? And I don't have the answer, but it's frustrating to see that. And now you would ask, but why this happened? Why this happened in Israel? Anybody has the answer? Yeah?
Because you don't have access in all countries where the trial participants were included.
Absolutely. So access and global trial. And here, this was the number of locations. And in global trials, countries may have limited access to optimal care after the trials end. And my point is really, the elephant in the room, it's really an ethical dilemma because we are running those trials globally to get access and to get marketed authorization in high-income countries, mostly. And in those countries, after the trial ends, most people will not have access to those therapy. So I think it's really posing ethical questions. But I won't go into that. You can read this article we wrote about post-protocol therapy and this ethical dilemma. We studied that comprehensively with Alison Aslam and Vinay Prasad, how often post-recurrence therapy is an issue in a registration trial. What we found is that very often we don't have the data at all. I mean, maybe you faced that also in IQWiG. You don't have data at all to assess post-protocol or subsequent therapy. When you can assess, it's often suboptimal, and overall, it's a limited number of trials that can be assessed with data assessed as appropriate. In the advanced setting, it's more or less the same findings. We found that 12% of the FDA approvals over a three-year time period had available data assessed as optimal. So my point about post-protocol, I think it's a very overlooked aspect in oncology. And if we believe overall survival is still very important, we should really have a strong focus on this. It really questions the trial's validity in settings where optimal care is available, and it's a key ethical dilemma posed by global trials. Okay, now trial design. So this will be pretty fast because I really want to spend some time on informative censoring, and the time is running. So first, false positive. We all remember the story of olaratumab. Olaratumab, I think it was a phase 1-2 study, and this was not the primary endpoint, but the overall survival. So it was in sarcoma, olaratumab plus doxorubicin against doxorubicin, and there were a very impressive overall survival benefit. So of course it had to be confirmed in a phase 3 trial, but the product was marketed. I don't know in Europe, but it was marketed and on market in the US for some years. And keep this shape of curve in mind, when you have an early separation, keep in mind for later. The phase 3 trial was run, and it was called negative. So it's really a lesson here. Sometimes in phase 2, when it's underpowered, you can have results that are only by chance, and you should really be cautious about that. Detecting a statistical difference which is clinically not meaningful. I remember this trial, erlotinib plus gemcitabine compared to gemcitabine, and the median gain, which was statistically significant, was 11 days. And here, sometimes the median is confusing, you know that. But it's not just the median. Look, the curve, they are almost superimposable. So this kind of statistical significant difference is not clinically meaningful. And I think this was really driven by the sample size inflation. Here, it's a very elegant work where they check for the median sample size in randomized clinical trials, and see that over a decade, it's increasing. And of course, with many, many patients, you will find even tiny, but still statistically significantly different differences, which are not clinically meaningful. And I just want to highlight again the FOLFIRINOX versus Napoli-3 study, where you see that in FOLFIRINOX, you have 324 patients. In Napoli, it was more than double. The comparator was not the same. But we see this kind of increasing in sample size, and we should be always worried when there is a lot of patient about the significant clinically significance of the results. You should always be very cautious when you see modification in the protocol about sample size, but not only sample size, to avoid what we call the Texas sharpshooter fallacy. Basically, you find some results that are pleasant for you or for the sponsor, and then you say it was good. This is also data judging, p-hacking. But you know that's why we have to have pre-specified hypothesis and not do like this data judging issues. So trial design, be aware of false positive finding in early trials, even when statistically significant. Is it clinically meaningful? Sample size, I would say neither too big nor too small. Blinded, open label, I didn't spend too much time here, and which endpoint was used. Do you have any question, comment? You are still with me? Yeah? Can I drink? Yeah. Because I can't put the glass here, it will fall. Yeah. So now, I think that's one of the most fascinating part, but it had to be grounded in solid points. Surrogate endpoint, progression-free survival. Progression-free survival, as you can see, a lot of commentaries, and it's a long and still ongoing debate. I won't solve this debate. I think what is very important is to know how to define, know your endpoints. I will take an example, the CONTACT-2 trial. It was in patients with metastatic castration-resistant prostate cancer, already pretreated, already having receiving what we call an ARPI, this new hormonal treatment, and randomized between cabo-atezo, cabozantinib atezolizumab, which is toxic, more toxic than the control arm, and the control arm was ARPI switch, so patient already had this new hormonal therapy, which is called ARPI, abiraterone, enzalutamide, all this kind of treatment, and they received again another ARPI, and this is called ARPI switch, and we all know that it's a very poor control arm, very suboptimal control arm. So basically you have a trial with this and this. And a PFS benefit, a 2.1 months PFS gain. So first definition, PFS is a composite endpoint, and it's very often relying on what? On scans. This is adapted from Tito Forjo and Vinay Prasad. So these are the criteria of this composite endpoint: death, and this is what is justifying the name survival in the term progression-free survival. But new CT scan lesions, again CT scan according to some thresholds. PFS is also a time to event endpoint, meaning here, it's the real life of a trial. It's not all patients entering the trial tomorrow and finishing. It's really, during the time frame. And the Kaplan-Meier analysis is putting all the patients starting at day 0. Each line represents the patient trajectory, and the events are these steps. You are very familiar with it, but sometimes you have bigger steps, which can also be due by many events at the same time. Is it correlating well with survival in general, PFS? The answer is no. Usually it's a pretty low or medium correlation. It's rarely high. Is there a good correlation between PFS benefits and quality of life? Again, the answer is generally no. This was a study where they studied this correlation, which was not good. And I know at IQWiG you are very good in the correlation threshold. So this work, I'm sure you are familiar with. To me, the issue is that the composite nature of PFS may blur its clinical interpretation. If you think about it, death and an asymptomatic 21% increase on a CAT scan have very different clinical relevance for a patient. And yet they are both equally accounted for in the Kaplan-Meier curve. When you see the steps, you don't know if it's death, if it's an asymptomatic progression, or something else.
Clicking that away.
Okay. And in this work from Anushka Valia and colleagues, they reported that in the most vast majority of cases, we don't have the breakdown of the events. We don't know how many events were survival, how many events were progression, etc. You can have some clues in consort diagrams. In contact 2, for instance, you can see that there are many instances with discontinuation, other. What are these others cause? Where there are some deaths in this cause, but still, it's a minority of them. So in contact 2, we have an indirect clue that most PFS events were disease progression and not death. And to me, it really contextualizes the word survival. When you say to a patient, this treatment will improve your progression-free survival, the patient really hears survival. You think overall survival is better. No, it's not that. It's really the definition of the composite endpoint, but you have to spend time to explain this to your patient, and it's challenging sometimes. So when we talk about the contact 2 trial, limited PFS gain, serious adverse events deemed to be related to therapy much more significantly in the new therapy than in the control group, 16% versus 4%, and no overall survival gain. But in the abstract, the conclusion could be useful treatment option for patients with metastatic castrate-resistant prostate cancer and soft tissue metastasis. Do anyone know here why they concluded that? I just want to, so if it passed the IQWiG criteria, so I won't challenge you too much. But there were this subgroup analysis in patients with liver metastasis. So this is in the appendix. And as you can see, it seems to have a benefit. Hazard ratio is crossing 1, but it's 1.00. And again, the shape. It's really separating very early, and it was not powered for that. So you should be very cautious, and this kind of result, I would tend to dismiss those results most of the time. And even in the paper, they said, although this analysis was pre-specified and based on stratification factor, it was not pre-powered, and no firm conclusions cannot be drawn. Now, informative censoring. I have 10 minutes left. And basics of Kaplan-Meier. So what I find interesting in the title of their seminal paper, Kaplan and Meier talk about incomplete observations. And by incomplete observation, here are all these time where you don't know what the patient became, and this is really the concept of censoring. And in a clinical trial, again, each patient will either have the event or is censored. Censoring is not a bad thing. If you have a trial with a very few events, at the end of the trial, all the patient will be censored. So it's not to say censoring is bad. So censoring are usually tick marks or circles, and the definition is a point in time after which the event can no longer be observed, regardless of the reason. And we will see that the reasons are very important. I want to highlight the fact that the moment when you censor the patient is very important. First, you have an event. Then you have a censoring. Then, for the next event, the step will be larger because you have less patient at risk. Now, if you just modify one censoring patient, one patient was censored at the end, now it's early censored. See the effect on the curve. The curve is changing. It's an even larger step. So it really shows you, and these are real, I did it with some code, it's very simple Kaplan-Meier, but these are real. These are the real effects of such changes. So it really shows you how the moment of censoring can change the Kaplan-Meier curve. So what are the reasons someone is censored? In overall survival, they enrolled recently or did not present at the event. This is administrative censoring, that's what I said just before, or loss of follow-up. In progression-free survival, there can be a lot more reasons, and a lot of them are related, again, to CAT scans. I take the CONTACT-2 trial as an example. For PFS, as you can see, no administrative censoring, of course. And just a word here, the reporting is very good. The Lancet reporting is usually very good regarding censoring. They are reporting the number of censored patients, and they are reporting this kind of data, the reason for censoring, which I find very helpful. But here, new therapy before CT, no CT post-baseline, missed CT. I mean, it was missed assessment, but it's mainly based on CT. Basically, you have a lot of reasons related to CT scans and evaluation. So here you can really see how informative censoring can be introduced, and I will talk about that now. How it can be introduced are the reasons. Why would someone skip a CT, skip a visit, skip or withdraw from a trial? And the two main concepts are toxicity-driven censoring and disappointment-driven censoring. In the toxicity-driven censoring, you assume that maybe the patient that will not come back for the CT, that will not come back for the visit because of toxicity, is a frailer individual. And maybe this patient is also at higher risk of presenting the event. And now you are censoring this patient. So you are removing this patient from the analysis, and maybe the patient would have stayed and present the event very just after. So it would typically favor the experimental arm if this arm is more toxic. On the other hand, disappointment-driven censoring will happen in patients, for instance, they are randomized in a very bad control arm, and they don't want to stay in this control arm because they know, and maybe the physician will tell them, and maybe their friends will tell them. What do you think these patients are? These patients may not be the same patient as those that will remain in this very poor control arm. Maybe they are healthier individuals, maybe more connected, maybe they know a lot of other doctors, maybe they are eligible for competing trials. So here, it's an assumption again, but they may be at lower risk of presenting the event. And would have they stayed on the trial, they would have been late censored instead of early censored. And if that happens, this selectively retain higher risk patient in this arm, and this typically penalizes the control arm. Now, to be fair, I talk about monarchy, so I will talk about Natalie. And Natalie trial was 3 years of adjuvant treatment. The eligibility criteria are broader than in monarchy. It's again hormone receptor positive, HER2 negative breast cancer patient receiving now ribociclib plus letrozole, anastrozole plus gossarin med and prazole or the control arm. Again, letrozole and anastrozole, same control arm without ribociclib. Again, open label trial, and EDFS as the primary endpoint. And it's 3 years of adjuvant therapy. EDFS benefit, it's not so clear, but you can see the hazard ratio, 0.75, not crossing 1, p-value significant, and this was the New England Journal of Medicine report, the first report. And based on this report, the first thing, you don't have the number of censored patients here. And this is, I don't think it's good reporting, but we can estimate those through some techniques. I will show you that. So the techniques, basically, you reconstruct the curve, you digitize the curve with x, y coordinates. You put these x, y coordinates through a code, a very nice package called EPD from KM package, and you can estimate the censored patients. And here we estimated that it was pretty significant at 6 months, 6.6%, 10.1% is pretty significant, and we conducted various sensitivity analysis, assuming those hypotheses in Natalie. Maybe patients in the ribociclib group had some level of toxicity-driven censoring, and this would have retained lower risk of the event individuals in this group, and maybe some patients in the control group were disappointing and left the trial. So based on those assumptions, we published a first paper, we did some analysis, and we'll show you an update of this after, but we concluded this paper with the benefit is fragile, prone to informative censoring in open label trials. Now, informative censoring, is it important? After our publication, I have to be fair, the first report about informative censoring was in Monarchy by Tom Meyerson and Jan Tannock. We have our paper, but other papers, Tannock again, Sarosh Nirola, and now, recently, there were 2 papers in JCO Comments and Controversy arguing against our analysis and defending is the use of adjuvant CDK4/6 inhibitors in early breast cancer. So one thing is sure, you know, informative censoring is a hot topic as well, and it's important. Now I want to, you know, update my analysis based on the 5-year data. Because you can say, you know, as the data mature, early administrative censoring can decrease. So the hypotheses are still plausible. I will make a very quick detour through NADINA to talk about what I call informative censoring areas. NADINA was a very interesting trial in melanoma, stage 3 melanoma. One arm is giving neoadjuvant therapy, in the other arm is direct surgery. I won't go into the detail, but initially when the results were presented, there were high risk of censoring very early, and I was suspicious maybe there could be some informative censoring, and in this trial design with the arm very different, with the neoadjuvant part and no neoadjuvant part. But with longer follow-up, and I published this recently, with longer follow-up, you can see that the early censoring numbers are dropping. So most probably these early censored patients were administrative censoring, and this is very reassuring. With Nathalie, you don't have the same pattern. We have a lot of data. We have, I think, 4 publications. And when you plot the data, so these are the number of censored patients at different time points, according to the follow-up with the different publications. When you plot this, you can really identify an area where it's stable, and it's what I call an informative sensing area, where possibly some significant rate of informative censoring happened. Again, it's hypothesis, but I think that's an important concept. So now I come again to the most recent data of Nathalie, 5-year follow-up, and first, this is the result, 4.5 absolute benefit. So number need to treat in terms of EDFS now is 22. So again, 22 patients need to be prescribed 3 years of ribo to prevent 1 EDFS event after 5 years. And how I can explore informative censoring now. I will show you what we can do with pseudo individual patient data based on digitized curve. And this is the introduction of the breaking ice application. This is an application when you can really visually explore this data based on what I explained you. And the new version was released 2 days ago, and I will show you an example of what you can do. I think what is interesting, you can really do automatic searches for censoring alerts. Basically, you will set some hypothesis, and you will try to find the minimum number of patients to be changed to find a censoring alert, and the censoring alert is triggered when your result is no longer significant. Let's see what we can do. Okay, so you select your PDF. Now you go in your PDF, you have some capture guidance, and based on this capture guidance, you will capture your Kaplan-Meier plots, and you will have an automated extraction, and it will abstract a lot of things. It will abstract the curve, the axis origin, Y max, X max, and you have to verify. I have to say, I had to train for this because, as you can see, the zero are not really aligned with the line. You see, the zero are very tricky so you have to replace that. I have to train, but that's okay. So you have to set the X max, the IY, the Y max, and the origin, and then. You see, it was tricky. I have to train. It was not easy. And then you will, you can verify. You can also edit curves and see if your curves are well drawn. You can use opacity. You can see the full curve. You can select for the other arm to see if it's okay as well. And you will have to check if the hazard ratio, original hazard ratio, was correctly abstracted. You have some quality control. And here, the hazard ratio is totally off. But maybe some of you noticed the control and experimental therapy were swapped. So you swap it again. Now it's correctly assigned, and the hazard ratio difference between original and reconstructive curve is very low. Then you can go into the breaking ice application. And in the breaking ice application, you will have many things. You will have censoring data after each time point. Here. You have the statistical output of your reconstructed curve based on pseudo-individual patient data. You have some tables, summarizing the number of patients, not cumulative. And then on the left panel, you can run some sensitivity analysis. Toxicity, disappointment, or both. And I saw we have the informative censoring area, possibly, during the first 18 months in Italy. So here I will run this analysis for this time frame. And the alert will be that if you modify 26% of the censored patient over this time in both arms, and you apply to them some modification for toxicity, you will transform the censoring into events. For disappointment, you will transform early censoring into late censoring. And then you can see that what we call, it triggers what I call a censoring alert. So I'm not saying there is informative censoring, but this is possible, and this should be explored. So it's almost finished. Again, the key assumption here is that some level of toxicity-driven censoring happen in the experimental therapy, some level of disappointment-driven informative censoring happen in the control arm. And to me, the benefit, I take the same sentence, but still fragile. I don't know. I don't have the real data sharing, so I don't have all the censoring data that could, I think, answer these questions. The last, equal censoring but still informative, I want to finish with the CONTACT-2 trial because it was interesting. It was high rates of censoring, but equally in both arms. As you can see, 21.5% in both arms. So there were no imbalance. And very often we say we should have imbalance in censoring to suspect informative censoring. And again, here you have a more toxic experience therapy and a very disappointing suboptimal control arm. And if you go on breaking ice, it really opens on the CONTACT-2 trial. This was really the kind of trial that allowed to construct this framework. And we see that by modifying only 6 patients per arm, the PFS gain would no longer be statistically significant. And we published this with Vinay Prasad. So OS is a direct clinical endpoint, PFS is not, DFS is not. They are prone to informative censoring, and tips to explore them: consort diagram, early censoring rate, imbalance, reasons, and use the breaking ice. If you want, it's free, it's free. My conclusion, so the control arm and subsequent therapy are really key. Study design, we know that, but informative censoring, I think it's too often neglected. This was a very famous paper from Jan Tannock. And friendly advices, usually it's more for clinicians, but I know there are some clinicians here. I think it's really important to develop and maintain our ability to appraise the data ourselves. It's not a skill, it's really what we are doing every day. What I prescribe to my patient, I want to know, the level of evidence, the confidence I have. And this is also enjoyable in the sense it gives more meaning when you understand what is going on in the trial. I think it's a very satisfying exercise. And it can allow your decision-making to be refined, particularly in some areas which are what we really very often face in medicine. I want to thank Professor Alfredo Adeo, which is my current boss in Geneva University Hospital, Professor Vinay Prasad, which I work with on several projects and influence my approach in this field, of course. Patient Geneva Ethics Committee, which I joined a few years ago, Saint-Léon-Bérard, which we have collaboration with. This is my research website. I'm co-editor of this new journal. If you have, I don't know if you are submitting papers, but you could be interested. And you can subscribe for free, again, to this oncology short letter when you will receive some articles in the mood of what I presented today. And I thank you for your attention.